Good afternoon, everyone. I am Priya Sareen Gupta, Medical Director of Clinical Community Programs at Mass General Brigham, here on behalf of Dr. Elsie Taveras, our Chief Health Equity and Community Health Officer. It's an honor to join you today at the Boston Globe Summit alongside our moderator, Kara Baskin, and my esteemed colleagues for this critical conversation about maternal mental health. As a mother of 2 young children and as a physician who has spent the last several years researching and implementing programs focused on maternal and child health, particularly for marginalized communities, this issue is very close to my heart. Healthy parents and families are the foundation of our communities, and yet many birthing individuals face alarming rates of mental health challenges, such as depression and anxiety, that jeopardize not only their well-being, but also that of their babies and families. Unfortunately, communities of color are disproportionately affected by this crisis, facing significant barriers to access to quality, culturally appropriate mental health care. At Mass General Brigham, we proudly supported the recent Massachusetts maternal health bill signed by Governor Maura Healey, which includes vital provisions for enhancing maternal mental health legislation, and the legislation underscored the need for routine mental health screenings during and after pregnancy, ensuring that new mothers have access to necessary mental health resources. The bill also mandated training for healthcare providers to better recognize and address maternal mental health concerns. It supports integrated care models that blend physical and mental health services, fostering a more comprehensive approach to the mental well-being of birthing individuals during the perinatal period. While we celebrate this progress, we also recognize that our journey has just begun. We must accelerate our efforts to tackle the alarming disparities that have long impacted the communities we serve. At Mass General Brigham, maternal and infant health is one of our targeted health equity and community health strategies. And as we all know, mental health is health. Through our Kraft Center for Community Health, Mass General Brigham is excited to pilot a new mobile model aimed at addressing these challenges directly and in a more integrated way. The recently launched Mobile Postpartum Care Unit program is designed for patients who are at higher risk for poor health outcomes, who live within a certain radius of Boston, and who have given birth or are planning to give birth at Brigham and Women's or Mass General Hospital. Patients enrolled in this pilot work with a dedicated postpartum care team, including a certified midwife, a community health worker, a licensed mental health worker, and a physician specializing in maternal health. For a 6-month period, care, including mental health support, will be brought directly to the patient's home through one of our community caravans and online telehealth services. The mobile postpartum care unit is designed to eliminate barriers to access, such as transportation challenges, ensuring that all birthing individuals, especially those in underserved communities, receive timely and culturally sensitive mental health support. By bringing care directly to our patients' homes, we aim to build trust and foster engagement, leading to better health outcomes for both parents, their children, and families. Thank you for being a part of such an important dialogue. I am so looking forward to hearing from our expert panel on this topic, so together we can develop impactful strategies to drive meaningful change.
Thank you so much. My name is Kara Baskin. I am the creator of the Parenting Unfiltered column at the Boston Globe, and I'm delighted to moderate this panel, not only because this is something that I write about quite a bit, but as the mom of 2 children, I've also suffered from mental health issues directly postpartum, and it's something that I feel very personally connected to as well. So thank you all so much for being here. I know we don't have a ton of time, but we're gonna make the most of the time that we do have to tackle this topic. And you know what I'd first like to address, and we could just go all in a row, Nicole, Divya, and then Lee, just to start us off, how did we get here? This seems like an insurmountable problem that did not obviously start overnight. What led us to this point, do you think?
Sure, thank you for that question, and also thank you to the Boston Globe for giving us the space and time to have this conversation. Again, my name is Nicole Christian-Brathwaite. I am a child, adolescent, and adult psychiatrist. I'm also a survivor of postpartum depression. And to answer your question on how did we get here, specifically thinking about Black women and the disparities that exist and the much higher morbidity and mortality rates, we got here because of racism. And it sounds like a simple answer, but it's an incredibly complex problem. You know, I say as a Black woman, I'm not at risk of dying at higher rates than my white counterparts because I'm Black. My Blackness has nothing to do with it. It's the systems of oppression. It's the racism. It's systemic. It's interpersonal. You know, unfortunately, and we've seen in the news all the time, Black women are not heard, we're not seen, we're not respected, and it's causing us to suffer and to die. And truthfully, that's why there are disparities across medicine, but particularly in maternal mental health.
It's such a pleasure to be here. Thank you to the Globe. Thank you, Kara. It's such a pleasure to be here with you, Nicole and Lee. My name is Divya Kumar. I'm a perinatal psychotherapist in private practice, also on the board of PSI, Postpartum Support International, chapter of Massachusetts. I just co-sign to racism, Nicole, all day, every day. And I would say before I became a therapist, I was a public health person, and I haven't worked in that sphere for a minute, but I wish we had seen perinatal mental health, and I hope we do see it, as a public health problem, right? Because our failure to see it as a public health problem has led to this inability for cohesive, systemic, sustainable action to really address perinatal mental health on the long term. I was a kid in the 80s, and I think about drunk driving campaigns, anti-smoking campaigns. When I moved to Boston in 1999, you could still smoke in bars. Now you can't, because it's a public health issue. And I think about and using seatbelts, the large scale, long-term public health campaigns that were undertaken by large systemic forces that really, we've seen the change. And we are here now because we haven't done the same thing with perinatal mental health. And like Dr. Gupta was saying, we have all these wonderful programs with screening, and we've made headway, and the MGH program is a wonderful example of this. But screening is one piece of it, and I wish we really could focus on the primary prevention. And without primary prevention and seeing it as a public health issue, that's kind of how we got here.
Lee.
So, Kara, thank you, and thank you to your colleagues at the Globe for the wisdom to have a program like this, have a discussion like this. I think it is so long overdue. So I'm just delighted to participate. My name is Dr. Lee Cohen. I'm the director of the Center for Women's Mental Health at the Massachusetts General Hospital. And in a way, as I heard you sort of pose that question, how we got here, I sort of had to think and step back because I think, Nicole, I think the issue that you raise about, frankly, differences in morbidity and, frankly, in mortality in marginalized populations, whether you're talking about here in Boston or across America, I think it's a huge issue. But I actually think back 15, 20 years to sort of how we were sort of not there in terms of acknowledging that 1 in 5 births in America across sociodemographic lines, across racial lines, was going to result or be associated with a mental health complication. And I was so pleased when now years ago, Governor Patrick had the wisdom to partner with Representative Story to establish the Postpartum Commission, because I think it was one of the first deliberate moves to sort of put perinatal mental health front and center, particularly in the Commonwealth. And I've been so privileged to participate and to sort of, to think about how complex the issue is. It's actually simple and it's complex, because we thought at the beginning it was all about screening, and we've come so far in that regard. But I also think I'm sort of disappointed, because I think what we've really learned is that on the other side of screening, as we look at women across the Commonwealth and across people who live very different lives in very different conditions across the Commonwealth, that we're still not getting those women the appropriate access to care.
Well, that leads me actually, thank you, to my next question. And I'd love to hear from each of you on the front lines. What are you seeing in your day-to-day work? What is troubling you the most? And maybe, Divya, we can start with you, but anyone can jump in, as needed. What are you most concerned about?
So I am a psychotherapist, so I see clients, perinatal clients every day, pregnant or newly postpartum, and early parenting too. And the thing that is so profound to me, I find myself saying, well, yes, that makes sense. Yes, that makes sense given the context of our world. I see so much anxiety and quite frankly, trauma, which again, makes sense given the cumulative impact of the past several years. This increasingly hostile, violent, unpredictable, uncertain world that we live in. People are struggling with all kinds of oppressions, you know, like Nicole was talking about racism and marginalization, but cost of living, it is so expensive to feed a family and to pay your bills. Many people live without family support. People are worried about the climate. People are worried about school shootings. How many school shootings have we had recently? My son was in kindergarten when Sandy Hook happened. I was like, surely we're gonna fix this now that somebody killed kindergartners. But no, that was in 2012. Threats to our bodily autonomy. Just look at everything that's happened in recent weeks. Racist comments about Haitian migrants that are found to be unfounded. The execution of a Black man just this week. People, and violence across the globe. People come to session and they're like, oh my God. And it's woven into the transition to parenthood. How can I, as a woman of color, parent 2 brown children without worrying what is going to happen to my babies? What is gonna happen when they go to school? What is the world gonna look like for them? One child has a uterus. What is gonna happen to her and her bodily autonomy? And that's what I see every day.
Parenting feels fraught.
It's fraught, and we live in this collective social trauma. You know, many people had babies during COVID times.
Right.
Talk about uncertainty, right?
What do you think, Lee?
So, I mean, I think that Divya, as you always have, sort of paints this incredibly clear picture of the various pieces that, in my mind, increase the volume in life in a negative way. It's already tough to be a mom in America, and the pieces that you sort of highlight just make it that much harder. When I'm in clinic, though, and one thing about being a clinician researcher and one thing about training at the Mass General is, you know, it's such a privilege to still see patients. I think it's sort of taking care of patients is our North Star. And one of the things I'm particularly sad about is that we can treat postpartum depression. We have non-pharmacologic interventions. We have older pharmacologic interventions. We have newer pharmacologic interventions. We know how to get new moms well. But what we also see is that for birthing persons, wherever they are, access to those treatments, how to navigate this space so that women who are suffering get treated and then get well. That's the piece that I think keeps me up at night, frankly.
And we're going to go back to that, but Nicole, I want to hear from you as well.
Sure.
What are you seeing every day?
I'll start with some positive.
Okay. I was very bleak, sorry. You can do that.
I mean, like, there's reality. But I think one positive I'm seeing, I mean, postpartum depression is the most common complication of childbirth. And somehow, as a physician, when I had my first son, I was not aware. I did not know I was at risk for postpartum depression because of prior miscarriages, because I had struggled with depression, and because of a traumatic birth. No one told me. And I will say the one positive is at least people are talking about it. And whenever I have a pregnant friend or I know a pregnant person, I'm like, check on them. Ask how they're doing. You know, when they're postpartum, don't just assume it's the baby blues. Have that conversation. I went through 3 months of prolonged depression and sadness, and to the point where I was suicidal. And then I sought treatment, and then it took many more months to actually access care, but no one would talk about it. And so at the very least, conversations are being had and awareness is increasing. Now the other side, in terms of where we are, I think my biggest concern is that there's just not enough education and awareness in the medical field amongst providers. I frequently receive referrals from people who have worked with an individual for years and then they become pregnant and they don't want to treat them. We can't be afraid of treating pregnant or postpartum people. That does a disservice to our population. And we're also not teaching about the inequities. People, our doctors, our therapists, our clinicians are not aware that marginalized people are at greater risk, that Black birthing people are 3 to 4 times more likely to die, twice as likely to suffer from a perinatal mood or anxiety disorder, but half as likely to be screened or treated. So those are my biggest concerns, is that the general population is aware, but the people treating them aren't.
Where does that disconnect come from? That is an excellent point, and it seems so shocking, really.
Honestly,
Why?
I would say it's priorities. Treating birthing or postpartum people is not a priority in medical education, and teaching our providers about racism, oppression, toxic stress, and how that leads to increased risk, we're not learning about that. We're not learning about how to screen in a culturally appropriate way. That's not a priority in medical education, in any type of clinical education. And so we are graduating doctors and therapists and clinicians who don't have the necessary knowledge to treat the populations who are at greater risk.
I mean, it kind of brings up this fact that motherhood is something that, on the one hand, I'm someone who writes about parenting a lot, and it is so vaunted on social media and in culture. What could be better than being a mom, right? That becomes your identity in a lot of ways, and yet at the same time, it's so woefully misunderstood from a psychiatric and from a health perspective that it really doesn't seem to make sense. So I guess the question is, how do we bridge that gap? Where do we go from here? If you were in charge, Lee, if you could make all the rules, what do we do next?
I think Nicole really nailed it, which was it's really about educating. It's about educating our patients, and it's also about educating our colleagues. Because Nicole, you really speak about two pieces. Because I think there's just, if you just look at the general population, and I liked your comment about sort of what goes on and what doesn't go on in medical schools and residency training programs, because those issues were really sidelined. And I think it's only been in the last several years that we've seen the issues of perinatal mental health coming a little bit more front and center. I'm thrilled about that. You then sort of add I think the next piece, which is that in that ecosystem, there's a whole other domain, which is we have populations that are at particular risk, and that whether you're a doctor, a nurse practitioner, a medical assistant, or you're at the front desk of that clinic, you need to be aware that the folks involved in the care of patients, including patients who fall into categories of being marginalized or who have special risk, that education needs to be broadened, and I think we're moving in the right direction. I'm thrilled to see that we have over 500 psychiatric residents in a perinatal mental health interest group now. That's only started in the last 2 or 3 years. How terrific is that? We started years and years ago. We were a small clinic, a couple of people, and now we have 500 of, frankly, the future. And I'm so thrilled to see that level of interest in perinatal mental health. And also, I think there's a huge interest in disparities. I think there's this growing awareness in our youngest colleagues that it's not just one world out there, it's not one system, and that we need to be really particularly sensitive to how heterogeneous our patients are.
Well, and I think that is the point that I would want to make, is an integration of care, that we can't talk about mental health issues or racism or trauma or any sort of disparities or marginalization without having all these conversations together. And my hope is that we stop working so much in silos, and that if I go to a grand rounds for OB residents, I'm like, perinatal mental health is the most common complication of childbirth. Everybody's got to be integrating this. They're like, oh, or if I get a client who had this high-risk pregnancy and nobody talked to her, nobody said, hey, by the way, you are at risk for anxiety and OCD, all these mood complications, because you've been afraid for this entire pregnancy. And she was like, nobody told me this. Nobody told me. Because we know that all these issues are connected. We have to start talking about them together and really integrating systems of care. And if I had my way, we would embed behavioral health everywhere that birthing people and new parents are, to make sure, the MGH mobile model, which I'm bring the mountain to Muhammad, make it where.
What does that look
are.
like? What is it? Could you sort of walk us through what would, in a perfect world?
Me all the money. What would this look like?
Money being no object.
Oh, listen, also, there's money where no object. The government would pay for parental leave because all these interventions would have a much greater impact if people had time and didn't have like 10 minutes on Monday at 4 to have therapy. They were actually had the time and support that they had to make the decisions they wanted to make for their family. That's what I would say. What does this look like? Imagine that you are a new parent and you go into your pediatrician's office for, I don't know, like a two-month checkup, and say that there was a social worker there who would come in, or a community health worker who would come in and check in with you, how's everything going, screen you with an Edinburgh. Do you need support around lactation? Do you need support around, you got a good diaper supply? The Yale diaper study, diaper supply increase was related to decrease in postpartum anxiety, because spoiler alert, babies need diapers. And to like, if somebody did need any of these services, they would be available in the pediatrician's office where somebody is, like the mobile care unit. You need to go talk to somebody about housing, there's somebody here. You want to make an appointment for a behavioral health person, she can see you now, or maybe you can come back Tuesday at 2. To just have everything in-house to reduce barriers, increase timely access to care. Have it all there.
Mm-hmm. Care is fractionated at the end of the day today, and we haven't really come up with a model of really integrated care across domains, from the most basic to from diapers to antidepressants. Mm-hmm. It just doesn't exist. And Kara, your point was sort of also, I think, spot on, which was sort of what perpetuates these myths. We just finished a documentary film. I think it's one of the first documentary films on postpartum depression. We just had our first screening this week at More Than Blue. We're excited about it. And what did we learn? We learned that the experience of women in America as they interface with social media platforms, the disconnect between what's on those platforms, and I'm not being critical of the platforms per se, but the view, the expectation that is there about what motherhood is really going to be like versus what, frankly, parenting and motherhood is going to really be, what it ends up being. The difference in that expectation and that reality really can wear on the soul of a new mom. I mean, we see it in clinic, and we see it in studies.
We live in this self-care era, and yet it couldn't be harder to take care of yourself.
Exactly.
That's the irony. Nicole, what were you going to say?
I mean, again, my fellow brilliant panelists, I completely agree. I think in addition to the lack of cohesion throughout medicine, I think there's a lack of cohesion in our society. And to truly address this, I think we have to start on every level. When, again, thinking about disparities, we'll have the individual trainings. But it's the residents or the medical students or the clinicians, but the CEO and the president, the people, the CFO, the people making the decisions, they're not engaged in these conversations. We really do, when we're thinking about inequities, when we're thinking about maternal mental health, recognizing if we support and target our most marginalized individuals, that will support everyone. But starting on the interpersonal level, so educating our clinicians, educating trainees, and then the institutional level, what is the hospital doing to reduce maternal mortality rates? What is the hospital doing to ensure that Black women don't continue to die and continue to suffer and continue to walk into appointments and walk out without ever being asked about depression? And then we're thinking about on a systemic federal state level. Again, Massachusetts, I think, is very forward-thinking and forward-moving in how they're approaching maternal mental health, but this is one state. What are the other states doing? What is the federal government doing? And until it's addressed at every single level, people will continue to suffer. People will continue to die. And we can't continue to other our most vulnerable populations, right? Like, even when we're in medical school, there's a women's mental health. Like, it's health, right? Like, mental health is health. Disparities is health. I should not have a 1-hour block about racism. It should be integrated into every course. Even, dermatology, they don't see Black skin, so then Black people die at higher rates of skin cancer because no one's catching it. It's the same thing. We're not learning about different cultures and how certain cultures present with more somatic or physical symptoms, so we're not screening, we're not asking, and we're dismissing, or we're ignoring the pain because there's the assumption that Black people have thicker skin. Like, the examples are endless, but if we are not willing and committed to put the resources, the people, the money, the power behind actually changing these numbers, it won't change. It can't just be a 1-hour course. It needs to be integrated at every single level, and that commitment needs to be ongoing. It's not a one-time thing. This has to be a lifelong fight.
And just to try to get access, I even know myself trying to find a therapist, the waiting lists are so long, it's often not covered by health insurance. Maybe, I mean, this is a whole other conversation, but I think I would be remiss not to say, a lot of times it's just not covered to get that kind of care. It's not covered by health.
And Kara, it's not covered, but even if it is covered, that's why I commented before, navigating
That's right, yeah.
Navigating that space. I was sitting with a patient recently, has postpartum major depression, and she says, like, let me get this straight. I just got this booklet with a list of from my insurance company with a list of providers. Am I really, and no one has time, am I really supposed to go through these? And she's ill, and she's being asked, and frankly, she doesn't have a tremendous support system. That's more than trying to run up a steep hill. And Nicole, I loved the way you sort of framed it, that if we're going to have a solution, it's going to have to be both bottom up and top down. Right. I don't see it happening unless we have both sort of folks, boots on the ground, and as well as a level of wisdom from really at the government level. I think what Dr. Biden is doing by taking perinatal mental health and putting it front and center, in my mind, one of the first times, is huge. And I think it's just the beginning, and I loved your, it's not a sprint, it really is going to be a marathon, but I'd like to be optimistic.
Well, on that note, so we have a little more than 2 minutes left, so we're going to do the lightning round of what makes you excited about maternal mental health care now? Where could we look for some optimism and some hope? Nicole?
I mean, I think I am excited about the people doing the work. I mean, like, just in Massachusetts alone, there are superstars everywhere. Like, you look at the people who were involved in creating the bill and passing the bill. I sit on the board of directors for the postpartum.
What's the bill, for those of us at home who don't know?
Talking about expanding access, ensuring that mental health care is covered, covering doulas, ensuring that people have someone there to support them and be a voice if they can't speak for themselves. And obviously it's much more detailed than that, but just, a quick summary is, birthing people matter. And they need support, and they need coverage, and they need access. So I'm excited that there are so many activists and people who are committed to this, and this is not a fight that any of us have to do alone. But it is a fight.
Divya, real quick.
I'll go fast. One thing is the Perinatal Mental Health Alliance for People of Color, which is part of Postpartum Support International, which is the largest perinatal mental health organization in the world. We call it the Alliance. It is an organization that I helped co-found in 2017 with 2 wonderful colleagues, and it is building capacity in the perinatal professional field. Mental health field specifically for to better serve folks of color, birthing folks, and the program has grown so much, and it is doing exactly what we intended to do, and it's very exciting to me.
And last but not least, Lee.
So today, I was excited, frankly, years and years ago, as this field started to sort of evolve, and I'm excited today that we have effective treatments to get ill patients well. And I also think that there's a more collaborative spirit of the folks involved who partner to get together, whether you're talking about a doula, a lactation consultant, a perinatal psychiatrist, a social worker. I think there's a willingness today to sort of reach in a cross-disciplinary way to try to get patients who are suffering well.
Thank you so much. On that note, thank you all for joining us, and I'm going to throw it back to our closing remarks. This has been great. Thank you all so much.
Thank you.
Thank you.
Thank you all for coming, and thank you for this amazing discussion today. I think so many important issues were brought up, and as a physician working in this space, I'm just leaving this conversation inspired to think about ways that we can really elevate the integrated models with all of the different components that we talked about today and move the needle on the care that we bring for birthing individuals.